I'd now like to introduce Dr. Simone Macindoe, who's an ortho-geriatrician from Waikato in New Zealand. Dr. Macindoe is a passionate advocate for utilising clinical audit to promote service change within the hospital environment. And she's going to speak to us about delving into the data, exploring the utility of the Prognostic Nutritional Index. Welcome.
Green. Yeah. Thank you. Okay. So firstly, I have no conflicts of interest. The Australian New Zealand Hip Fracture Registry, Waikato, has been participating since the middle of 2017. And for the first time last year, the HIP report included mortality data. As you will remember, this is pooled data from the start of 2018 to the end of 2020 for 30-day mortality, and from the start of 2017 to the end of 2019 for 365-day mortality. Looking at this graph, New Zealand is the orange dots for 30-day mortality, and Waikato came out just above 1 standard deviation from the norm. Our 365-day mortality was supposed to be 3 years complete data. We actually only had 2.5. Again, New Zealand is the orange dot. And Waikato came out in the 3rd standard deviation. I received a phone call saying this would be coming out to the media and we might be asked to explain. Just as an aside, this year, 3 complete years, we've come back completely on the average, which is quite a relief. So the question we asked ourselves was, why were our mortality rates so far outside of the norm? We've always said that our patients are older, sicker and frailer, so are they older? From this year's data, we do have a lean towards slightly older patients, and in fact from last year we had 25% of our patients over the age of 90. Are they frailer? Well, this year we can actually show that they are indeed sitting slightly on the frailer side. We then went on to do a mortality audit. We looked at patients for the whole of 2020. We had 297 hip fracture patients in that year, with 120-day follow-up available for 296 of those patients. Our mortality at 30 days was 8%, as expected, and our 120-day mortality was sitting at 19.8%. We did a complete notes review for the 34 patients who died between 30 and 120 days post-op. This showed that 21 of those 34 patients had known moderate to severe dementia, and all of them were admitted to hospital level of care. This has sent us off on another plan to look at these patients. Unfortunately, that's been stymied by COVID. We're just getting back to the point where we can implement that. We then looked at these patients and asked the gold standards framework surprise question, which is, at admission, would we be surprised if they were to die in the next few days, weeks or months? The answer was no for 44% of the patients, but actually 56% of the patients we were surprised. So what don't we do well, and could we find an intervention that might affect the outcome? We were discussing some ideas, and one of the things that we knew was that at Waikato we're not permitted to routinely use dietary supplementation following a hip fracture. This has caused some concern in the past and several frank discussions which have resulted in nothing. Our concern was heightened particularly after one of our patients in her 90s with a BMI of 15 and a 10% weight loss over the year was seen by a dietitian. The outcome was that intervention was not needed as she was currently eating well. No surprise, we were quite concerned. So Sandra, my CNS, was doing some research. She looked at the recent publications around hip fracture and came across one which was talking about the Prognostic Nutritional Index, or the PNI, after hip fracture as a predictor of outcome. This prompted some further investigation into the tool. So what is the PNI? PNI is a nutritional screening tool that seems to have come out of mostly Asia. It's calculated as serum albumin plus 0.005 times the lymphocyte count in millimetres cubic, which for us is serum albumin plus 5 times the total lymphocyte count. The PNI was initially developed in 1984 in Japan, and was found to be an independent predictor of mortality in patients who were malnourished with upper GI cancers. Over the years, it's been increasingly shown to be a useful tool for predicting mortality in GI cancers, liver, solid tumour cancers, and more recently with both COVID-19 and hip fracture. It is a proxy for nutrition, immunity, and inflammation, and it's a pre-treatment risk stratification tool. It's better than albumin alone. So our audit, we reviewed all the patients with hip fracture aged 50 years and more who were admitted in the first 3 months of 2018. The number was 87, and we had complete data in 84. We collected the admission albumin, the admission lymphocyte count, the days of survival, and we did that by reviewing hospital notes, GP data, prescription collections, and we searched the death notices as well. And we did a retrospective Charlson Comorbidity Index on all of these people. We had a lot of data, and we were wondering what to do with it because we didn't quite know where to go from there. So we phoned a friend who happened to have a friendly biostatistician on tap. We had some very useful stats, as it turned out. We set survival at 1,000 days as an outcome. There's been a little bit of work at home around looking at 1,000 days as a predictor of mortality, particularly after admission to rest home, and some association with frailty and pre-frailty. Firstly, there was no correlation at all between Charlson Comorbidity Index and survival. We then used cross-tabulation and were able to show that a PNI of 43 shows an increase in survival and a reduction in mortality at 1,000 days. So cross-tabulation was essentially where they used the numbers to look at what point did more people live than died. In this case, living is the green bar and dying is the blue bar. This shows slightly better when we look at a scatter plot of survival against the PNI. And if you set survival at 1,000 days and look at a PNI of 43, you start to see that almost everyone below that has passed away. It shows even better with a Kaplan-Meier survival curve, and we had a nice significant difference. There are, of course, some very good alternatives. The MST and the MNA are both well known and well recognised as screening tools for nutrition, but they are timely and the nurses often don't quite get time to fill them in on the ward. Also, most of our NOF fractures are older. Up to half of them have delirium, which is often present when they arrive on the ward. And 40% in 2021 had a premorbid diagnosis of cognitive impairment or dementia. The other thing I find really common is nihilism, so people often underestimate their weight loss or underreport poor nutrition, and this is particularly when they're in the acute environment. So, was there a clinical utility of the PNI at Waikato? We were wanting to use the PNI as a tool for referral to the dietitian, with a cutoff of 43, which is based on local data, that generates a dietary intervention, which means supplements, regardless of apparent good nutrition. We acknowledge that it's a utility which is time-based. We're not going to see any good results for some time, and in fact we can't even assess it for 1,000 days from the beginning of the intervention. The expectation is, however, that we will pick up people who are frail or pre-frail and provide an intervention that has a theoretical potential to reverse pre-frailty or early frailty, and certainly to get supplements in earlier, because we know that it's one thing we can do which is actually effective in terms of outcome. Our aim, of course, is to reduce mortality rates in this group. Our progress: we are now adding the PNI onto dietitian referrals, educating the ward dietitian to understand the relevance to our patient group, and our aim is to establish a follow-up after 3 years of intervention. Thank you very much.